Good afternoon, everyone. Welcome to the 149th episode of the 988 Crisis Jam. Really excited to be here with you all today. And this episode is going to be focused on kids crisis units and mobile teams. And the presentation will be by Lindsay Stone, who's the Senior Director of Child and Youth Mental Health Program with Knox County Children and Youth Center. So Lindsay, thank you for being with us. So as those of you in the room are aware, slightly different process for getting into the Crisis Jam. You now have to pre-register, so make sure you pre-register before you want to come in, and ideally you do it more than 5 minutes beforehand, like I did today. But make sure to tell your colleagues and anyone who wants to come to register. All of this is on talk.crisis.now, along with signing up for the newsletter, all of the previous materials, all of the previous sessions. So all the good information that's always been there. Next slide. Last week's session, which I actually have to go back and listen to, but I heard great things about, was focused on AI and the role in crisis care and a debate there. So I know that's a huge topic right now, both in the field, but in the popular discourse. So great session to go back and take a look at if you weren't there for that. Like all other sessions is available along with, as I said, the other materials and news, etc., on the website. And also on the YouTube channel, here's a list of the top 5 sessions. You can go back and watch those if you missed them, or if you just want to revisit some of the learnings and the wisdom there. I did learn today that these have remained the top 10 for a very long time. So these are crucial topics that many of us are really engaging with, struggling with, trying to figure out. So great set of resources and amazing speakers. So the Crisis Jam team has been able to host over 400 unique speakers over the last 150 or so episodes. And they're starting to plan for next year. So if you have ideas of speakers, of facilitators, of topics, of types of what we should actually do in the Crisis Jam, then send those over. They're looking for those. And this is a great slide. I love this one. This is just a who's who of everyone. Now, onto the, oh, thank you. The who's who of folks who have spoken on the Crisis Jam. And then next, we have the list of news items. So this is a great one here, really related to the topic that we're discussing today, focused on exploring children's mental health with the American Foundation for Suicide Prevention with Dr. Christine Moutier and Vic Armstrong, who often has a segment on here and is a frequent Crisis Jam contributor. This next one, which got us into a question of actually how old are Gen Zers, but this was a really interesting article that CNN has looking at some research about, do Gen Z struggle more with mental health than millennials? And you can see here the poor and only fair mental health is highest for Gen Z among all of the generations that this study looked at. So a great article to check out and really related what we're talking about today. And very last, this sobering article from the LA Times, really focusing on the sky-high rates of restraint use in psychiatric patients at LA hospitals, and just a topic that I know many of us in this room really care a great deal about, and that the entire focus of this jam is really building out a crisis system that avoids, whenever possible, law enforcement, hospitalization if not necessary, and certainly connect people to care that is affirming, non-restrictive whenever possible, and non-traumatizing. So just a really great article to read and to keep in mind what the goal of our work is. Next slide. Care that feels like care, exactly. So just a reminder, all of the partner toolkit materials from SAMHSA, the tools that you can use to get information out about the availability of 988 in your communities, in your families, for your colleagues, et cetera, all available through SAMHSA for free. Tons of different types of materials available in English, Spanish, So go ahead and click on that and get materials either sent to you or printed. Next, crisis jam speakers. Do you want a short sleeve? Do you want a long sleeve? Do you want it in cotton? Do you want it in polyester? Well, you have those options. You can go pick them up on the website, but even better, you can volunteer to be a trivia hot seat participant, and then you get your choice of t-shirts. So just suggesting, consider. And so come on up. I'm welcoming to the stage our trivia hot seat presenter, Joanna Rosen from the American Federation for Suicide Prevention. Welcome, Joanna.
Thank you so much. Excited to be here.
Great. So, Joanna, the question for the audience, everyone put on your thinking caps. Earlier this year, Harvard University School of Public Health academics engaged 25 external partners and initiated an experiment to increase the dissemination of evidence-based and medically sound information on mental health. And the question is, which profession was not mentioned in relation to those external partners in the experiment? Real estate agents, part-time bartender, licensed therapist, or marine biologist? Which one was not? Now, everyone should have gotten a pop-up on your screen to select, so go ahead and submit your response. Joanna, you have the exciting opportunity to answer this question, and you know you have a couple of options. You can just go from your gut, tell us what you think. You can also poll. I think we get to actually see the audience first too, so you get to like decide if you want to go with the wisdom of the crowd, or you can call a friend. What are you feeling?
You know, I think I'm gonna pull the audience. I feel like this is a smart group. People normally know what they're talking about. I'm definitely thrown. I'm not sure. David saw my eyes. Yeah, I was surprised. I don't know if I fully understand the question. I mean, I do, but it seems specific. So we'll see. I would love to see the audience's thoughts.
I hear you. When I saw this, I was like, this is a trick question. I get it. There you go. Okay. Audience has got you for 60% marine biologists, 26% licensed therapists, and then the others are kind of pretty far behind that. What do you think? Go with them? Go with something else?
I guess I think I'll go with the audience because I really don't know. I feel like I'm trying to be tripped up with the C, licensed therapist, but I'm hoping that D is correct. So I'm just going to go with that.
All right, D's the answer. Let's see. You are correct, Joanna.
Okay, awesome.
So
huge relief.
I know, right? I also thought maybe they didn't include a licensed therapist in this, but what this was actually, I just heard about this recently, so this is news to me too, but Harvard was thinking about the fact that there's a lot of information on social media, particularly TikTok, about mental health through mental health influencers. Mm-hmm. And they were thinking that one of what's really important is to make sure that the information those influencers are putting out is really good and is informed by the best evidence that we have on mental health. So they did this experiment with several mental health influencers, one of whom is pictured here with her adorable dog, and bring them in to talk with them about best practices in mental health, what the research says. And so they included real estate agents, part-time bartender, licensed therapists, but not a marine biologist, all of whom were influencers. So congratulations, you got a t-shirt. You get a t-shirt whether or not you win. You get your t-shirt. Great job.
It'll be my second.
All humans have breakdowns. I'm just, I don't know, weird enough to do it in public.
And so these are some of the influencers, and what they did find was that at the end of the study, they were only 3% more likely to post the content, which doesn't seem like seems like essentially a non-result. But they thought about that and said, given the number of audience members that influencers have, that content was viewed an additional 800,000 times. So when we're thinking about how we're pushing out information, that's a huge resource and potentially an untapped pipeline for getting good information to folks. And so this is a influencer who's actually in New York. who talked a lot about, I think there's a quote here, but I'm not seeing it yet, but here we go. Harvard has this abundant knowledge base. If they can just find a way of connecting to the people doing the digesting, which I think is a really important reminder that a lot of people spend, particularly academics, people doing policy work, we spend a lot of time building out what we know best about what happens for people with mental health needs, what the needs are, what the challenges are, how we support them, or how we support us. And a lot of times we talk to each other, but we're not talking to a broader audience because we're not able to get that information out to folks who are not in academic or policy or practice spaces. So it's really great reminder of thinking about how to get that information out to where people are. So, and also guys, I hope this isn't going to continue having, my computer's a little slow today. So I think I'm getting a little bit of a lag, but I'm going to try for it not to be seamless on your, for it to be seamless on your end. But just in case you notice something, I just want to give you a heads up. Okay, we're here for our feature presentation on the Children's Crisis Continuum. So can I call up Lindsay Stone?
Sure. Hello to everybody. Happy Wednesday, and thank you for having me. I'm excited to have a few minutes to really share what we've been working on over the last couple of years at McNabb Center and really enhancing our crisis continuum and building services. And so you'll see our family walk-in center was our first one, but really just to take it back for a minute, what led us up to even adding services onto our continuum, which is I'm sure a lot of people on this call can relate to, it was the acuity that we were seeing in our outpatient services, the need in our community to have more immediate and intensive crisis support. And so we built a children's crisis continuum and added things over the past couple years. As you can see on the next slide, our family walk-in center opened in November of 2021 to really provide some intentional hours and a crisis episode period for families to walk in from 8 a.m. to 8 p.m., 365 days a year. And we have 24-hour on-call support after that. So the phone is always answered, but really from a long-term 6 to 8 weeks approach. So it's not a one-time walk-in and then we refer you out. You can have these intensive services that you'll see in the slide deck. For instance, traditional outpatient services like assessment and evaluation, case management, therapy, medication services, but with a crisis focus and with staff that are trained to address those crises. And we use those 6 to 8 weeks to set them up for long-term care and make sure that they have good long-term options. We are really thankful to take away the barrier of insurance. So there's no insurance required. We have a multi-grant system right now to where we're able to pay for all of those services and staff and take that barrier away from families. But for instance, one of the things to highlight the medication services that we did is to really take a non-traditional approach with it. So we have a prescriber for medication services on Tuesday afternoon after school, but we also have Friday nights up to 8 p.m. and then Saturday and Sunday mornings from 8 to 10 a.m., which honestly, most weeks I have a higher show rate in those hours than I do in my other outpatient clinics because it doesn't affect school, it doesn't affect parents' work schedules, and it allows them more flexibility in those options. And so as you see on the next slide, I wanted to give you all a visual of what it looks like, not just what we do, but really what families experience when they walk in. So what you'll see on the left side of your screen is our mindful moments corner. It's actually the first thing that kids see when they walk in. Kids have an art section when they come in the corner there, and they're able to leave an art or a drawing, something for the next kid that walks in. Basically, a connection point is what I like to call it, making sure that kids and families know that there are other kids showing up in these doors that walk in with stressors or maybe have similar experiences. There's a Lego table under that. There's QR codes for mindfulness activities that they can scan and take with them, really just looking at practical nuggets that they can take with them and feel supported. The middle picture is what I call our hospitality section. So we have a big open room. It's not closed off, lots of couches and familiar items, but they know where drinks are. There's a coffee maker, there's snacks always stocked. I always say you don't have to tell kids where the snacks are twice. They know where to go when they come through that door if they're coming for a follow-up appointment. And I love walking in to see a parent or a guardian on the couch drinking a cup of coffee while their other child's in treatment. And so the next slide is actually my favorite 2 rooms of our whole center. And I wanted to spend a minute on this because we intentionally made sure we chose a space that we had enough room to do what we call breakout or respite rooms. So the picture on the left is our young child respite room or breakout room. So it has things like a Nintendo Switch, kid-size recliners, a reading section, a whole fidget section that you can't see based on the picture, race car rugs on the floor, just a space for them to lounge that feels like a bonus room or a playroom. And then the right side of the screen is our adolescent room, basically PlayStations, gaming chairs, adult-sized beanbag chairs. There's a whole art therapy station in there, lots of windows for natural light. Our vision for creating this space was that kids and families would experience crisis in a different way, in a familiar, calm environment. And that's why we've set it up like this as well. I think we just said earlier, care that feels like care. That was it. That's how when that was said, I was like, that was our vision for this too. And so this environment has hopefully established that for our families, but we knew we weren't done with this on the continuum. In the midst of opening this, as you move to the next slide, we were awarded a 2-year SAMHSA grant to open Tennessee's first children's crisis stabilization unit. So this picture is when we did our ribbon cutting with East Tennessee Children's Hospital, partnering with them to put that children's CSU on the 4th floor of the hospital. Really a non-traditional approach for us. We have 2 other adult CSUs that are kind of standalone buildings for us, but we wanted it to be easy access in a familiar environment for our families and really to provide a regional approach. So you'll see on the next slide, we have a 12-bed unit for kids. Like I said, right there on the 4th floor of East Tennessee Children's Hospital, an elevator ride up from the emergency department, even though they do not have to go through the emergency department to get to us. It just gives them an access point. We know, and I think everybody probably on this call knows, that we plan to take the pressure off of emergency departments, medical providers, giving a space for more behavioral health care in our community. And so we're able to offer that for ages 4 to 17 at the unit. And so the next couple slides show you some pictures as well, because I'm a pretty visual person, so I want you to see what that space looks like. We were really fortunate to work alongside Children's Hospital and be able to construct that unit to what we wanted for children, knowing that we had never done this and there were no guidelines in Tennessee on how to do this for children. So the environment is set up very familiar for children. The picture to the right is one of our 3 group rooms. We have enough group rooms to break out age groups for groups or individual sessions, making sure that we're developmentally, when we look at a range of from 4 to 17, that's a pretty wide range. So we wanted to have space to do that. The middle picture is our staff celebrating our 1-year anniversary in June. You have to celebrate the milestones because it matters when you open new services. But the next slide has our bedrooms on it. We were fortunate enough to have the space at Children's Hospital to have a bedroom for every child. So they all have their own individual rooms. They all have windows and natural light. They all have their own bathrooms within those rooms, which really just provides a lot of dignity and respect for our kids, helps them feel comfortable. You'll see parent loungers in there as well. We created a couple rooms to make sure that we had space that if a parent of a young child needed to be there for a little bit from an attachment or a trauma-informed standpoint, that we created the space for that to be an option. And then yes, I see the comments in the chat. The room names are on the other side. We had one of our staff do the graphic design and name all of those, creating that sense of ownership for our staff to individually name all of our rooms for our kids. And so that gives you an introduction to what we've done over the past 2 years. But I wanted to spend the last little bit just really looking at what's working so far. And so what's our impact? That's usually what I get asked of, like, all of this is great, but is it working? So for instance, right now we've served kids and families from 24 East Tennessee counties. We're located in the heart of Knoxville, kind of East Tennessee region, but we've seen a bigger reach than we probably even planned to when we wrote both of these grants. And so serving 24 counties means that families are willing to come for that care because it's not everywhere. Families are willing to drive to come get the right level of care for their kids. From an access standpoint, at just the walk-in center, we've served 1,756 families to date. And the Children's CSU, just in a little over a year, has served 543 unique children and youth. So we're already seeing the need there, and it grows every month. From a diversion standpoint, which we're always looking at when we wrote the grants, we wanted to make sure that this was capturing a gap. It was filling a gap in a level of care that wasn't in Tennessee before. And so the walk-in center has consistently maintained an 87% diversion rate from higher level of care. That we're keeping kids out of inpatient care. We're keeping kids out of residential care and in their families for hope and healing if that's the most appropriate option for them. The CSU has maintained a 93% diversion rate, that they're able to access that level of care and stay out of those higher level systems. From a collaboration standpoint, you'll see our top referral sources on here. It's no surprise to me that the school systems and across our districts, and especially locally in Knoxville, have been our largest referral source to the walk-in center. We knew that before we opened this walk-in center that school staff at the end of a school day were making really hard decisions on whether kids were safe enough to go home. And sometimes the emergency department was the only other option if that home environment was not the best option. But now they have a place to send them for after school hours, which are our peak hours, as you can imagine. And then from the CSU standpoint, you'll see that the Children's Hospital Emergency Department is our highest referral source. But I love that our self-referral is second. So we're getting lots of families that are self-referring, calling, meaning they don't have to go into the emergency department. They don't have to go through a hospital setting. They can just come directly to us. And so I love that those are some of our top referral sources. And so the next slide touches on a couple unique ways that we were committed on making sure that we developed and adapted this to children and didn't just use adult guidelines when we created a children's CSU. The picture on the left is what hangs on every bedroom door in the CSU. It says, "What can I do during room time?" They have designated room time in the afternoon to just decompress, have some rest time. But that can be really isolating and triggering for some of our kids that don't know what to do with time alone. And so one of our residential counselors created a list on their door that they can read through and pick one of those items to work through while they're in their room. But what's most important, it's all items that translate into their home life, things that they can do outside of that environment, which is what we're setting them up to be successful in. The picture on the right is our diary card that they do during morning group every morning during goals group. Basically, we've put a lot of DBT therapy in our curriculum and using a diary card to help our kids learn how to rank their symptoms, notice their symptoms, and really be able to call those out. We also use that in treatment team every day to make sure that everybody's really driving at the same core treatment approach for all of our kids on the unit. And so just a couple more slides as I round up my time, our outcomes for success, just to give you a little bit of more practical knowledge about what we're seeing here. Our walk-in center averages 86 new walk-ins a month. We've been up to as high as about 124 new walk-ins a month. Obviously when school is in session, those are our highest peak months. But those are new walk-ins. Those are not ones that are in that 6 to 8 week period that I talked about. So we have a really high caseload and obviously staffing to address that as well. Our ages served today at the walk-in center, we've served ages 3 to 17, so a pretty wide range there. I mentioned earlier that the Children's CSU can serve 4 to 17. We have only served 6 to 17 from that age range to date. But I will say 9 to 17 seems to be our highest pocket of age group there. Unique things that we were able to do with our SAMHSA grant, we embedded a mobile crisis team within the SAMHSA grant that could be at the hospital to just go down to the emergency department and do those mobile crisis assessments, recommend level of care, but also be on the unit for us just to make sure that we were keeping kids in the right level of care. And again, just addressing extra support for our systems around us. Just this month, I'm proud to say we integrated a peer support specialist into our children's stabilization unit, making sure that we have that lived experience and that recovery mindset within the unit and the continuum so that our kids and our parents feel that they're able to move through this and this crisis period doesn't define them. And so I'm excited to see where that grows in the future. Our average length of stay at the CSU is 4.8 days. One of the things that we did uniquely for kids that we asked the state for is to not be bound to a 72-hour guideline because we have never done this in Tennessee. We don't know that 72 hours is appropriate for kids. And so we are able to keep them up to 10 days right now. And we've been able to track where that stabilization period is landing. Right now, it's about 4.8 days. We've only had 4% of CSU admissions be readmitted within 30 days, so really low recidivism rate. And 99% of families have been involved in family therapy and treatment while they're on the unit. And so I'll end on our last slide, except for just my contact information, really ending with their voices and not just mine. There's some quotes up here from kids that have come through our continuum. You'll hear and see words like that they felt understood, they felt safe, they learned about their mental health. Those are foundational things when you think about trauma-informed care. But the last two quotes are usually what I end on. The second to last one says, he came to school talking about a Lego table. That came from me running into a local elementary Knox County counselor a few months after we had opened the walk-in center. And she said, oh, I heard about your new walk-in center. One of my kids came to school on Monday talking about a Lego table. And it was in that moment that it hit me that the vision that we had came to life, that kids would experience crisis in a different way, that he didn't come to school on Monday talking about the stressor that walked him in the door. He didn't talk about what kind of stress he went back to in his family, but he talked about how he felt safe in an environment that felt comfortable to him, and he had a positive experience. And the last quote came from a 17-year-old male that came to our children's CSU, and they were writing future letters back to themselves in a group one day. And he left this letter with us, and he wrote this quote back to himself, and he said, things will get better. Just take care of yourself first. You are your most important person. And so it's been a challenge for me and my staff to remember that in short-term crisis stabilization, you get a short period for a reason. But if we can challenge people to be their best mental health advocates at whatever age they come to us, we have set them up well for the future. And so that is a good reminder for us to continue the hard work that we're doing. The last two slides are just the contact information, the addresses, phone numbers for the two sites that I mentioned, and my direct contact information if there's any questions following this crisis jam. But we're really proud of the services that we've developed, and we're continuing to tailor them to kids and youth in our area. Thank you so much.
Thank you so much, Lindsay. You're getting some great questions in the chat, which if we have some time after the discussants, I'll raise, as well as just props for some of the things people really appreciated about the model. It was great to hear people calling out the family involvement, individual rooms, the peers, many aspects. So thank you so much for that. And I personally just want to say I really appreciated the last slide, that the set of quotes, and the one that stood out to me, I felt understood and safe, which is really the feeling we're all trying to cultivate in the services that those of us who are service providers help stand up. So just thank you so much for that. So now I'd like to bring up our first discussant, Janice Cook, to come and give your reflections on what you just heard.
Well, good afternoon, everybody. I'm Janice Cook. I'm the Director of School Culture in Knox County Schools, which really covers all the support services that are not academically born. So the counsellors, the social workers, the mental health workers. And we have partnered with McNabb for many years. Knox County has really been invested in providing mental health supports for students way back for 30 years. 30 years ago, we decided that, we needed to take care of our students in their community, rather than sending them, as many school systems did at that point, off to residential treatment programs and sometimes out of state. We're a large school district with 60,000 students. So we have, and we have a lot of it. We're not a homogeneous school district. We have like different communities within our school district. So we have worked together with mental health supports, and we also have within our schools, not only the counselors and the social workers who provide some levels of mental health, we also have clinicians. We have 11 mental health professionals and 2 mental health case managers that work in our districts as well. But we have partnered with McNabb over the years to provide services within the school system. So the addition of these 2 programs specifically that they provide really helps us extend the continuum of supports we provide in that culture of care for students. We go back to, you cannot, mental health doesn't start when the kid is a crisis. We have to prepare. So we do a lot of work doing trauma-informed, making sure that all of our 90+ schools have had trauma training, and we're looking to be a trauma responsive district, and we look at the impact that it has on students. But as we go through, we have a lot of students who have significant trauma in their world and significant mental health issues. We have, by school board policy, been able to put in things in place like suicide prevention coordinators in each school, and they have kind of some responsibilities. We do work with our counselors and social workers to, work on that suicide assessments. And for example, up till this year already, we've had like 514 suicide assessments that we have done, through K through 12. So we have a lot of things that go on to support students within our district. But when it comes to the point where they need additional supports, and Lindsay's point is really well made, in that a lot of kids come to school and they feel safe, and they feel safe right until the time that they're about to go back home. And that's that kind of really critical time. So having somewhere that they can go and somewhere that we can refer them to in that time from 2 o'clock onwards, we have a lot of students who then come and reveal like just some of their anxiety, some of their concerns, and some of their fears. And we have to look to see, what can we do? So this program has given us the opportunity to be able to look and see, like we have another resource, and we are very fortunate and very grateful that we have that for our students.
Thank you so much, Janice. And it's great to hear about how this fits in with the work that you're doing at the county schools and how you see it as a resource for your students. I'm next going to call up Ron Phillips, who is our second commenter. Ron, can you give us a little bit about what you heard or your takeaways from this? Are you?
Yeah, I want to back up and support. First, good afternoon, and thank you for letting me talk. When McNabb first approached Children's Hospital, we looked at what we could do as a team, not just us, but what could we do as a team? Because as I took over the role of CNO and vice president, we saw mental health issues in our emergency department. And to Janice's point a minute ago, we would see an influx as soon as school was out in our emergency room. And we all know the emergency room is not the best place to treat a child, not for behavioral and mental health issues. It's just not. So as we started exploring what we had a vacant floor that we were not using. With McNabb's help and our funding, we were able to take that space and truly make a safer mental health space for those kids. So we have seen it as a huge win for our emergency room. We have noticed a significant drop in the number of patients that we're seeing that are short-term in the emergency room. They're not coming in. When you talk to the community pediatricians, when you talk to others, they're now going to the walk-in center. They're not coming to the emergency room, which was the goal all along, to keep kids out of the ER. Once they show up in my emergency room, they're treated like an emergency room patient, and that's not what they need. And we know that. And I am not a mental health nurse. I'll start with that. I'm a peds nurse, but I know enough that that's not what they wanted. So when Lindsay mentions the crisis stabilization unit, we've also partnered with some other things with McNabb, trying to provide more services wrapping around kids' needs, not miniature adults. What do those kids really, really need? So we're fortunate. I have a board and administration that truly supported that we had to expand. We had to do more than the typical emergency room. We can't keep doing the same thing and expect a different result. So all of those things that we've heard today, if you just step back for a second, any hospital in your region or area that's treating children has the potential to have the same issues we did. And more than likely, if they just think about it, they've got a solution like a crisis stabilization unit, but they have to have a partner. They've got to have somebody that understands the behavioral mental health side, because most of us don't. So kudos to McNabb from us. It's always a privilege to get to present the numbers. When I see how many kids were walking through mobile crisis, know what we referred there, it's phenomenal to listen to the stories from the kids that we know would have not gotten that same level of care 3 years ago. So I know that was quick, but I just can't express enough how much of a difference it made to our community. And it is one of the shining stars. The other piece of that, there was a question asked of me earlier today before this, is it our program? It is not. We literally lease that space back to McNabb. So it's not part of the hospital, which makes it even cleaner. They don't have to come through the hospital to get admitted. That is entirely up to the McNabb team. So with that, I will close. I think it's getting really close to the stop point.
That's fantastic. Thank you so much. Great to hear about how your relationship with that this intervention has developed. And also, I loved what you said about really thinking about kids as kids and not as miniature adults, and really building support around those needs. So thank you so much. And thank you for joining us. We actually have, 2 minutes. Lindsay, are you still here? There's a few questions in the comment section that I was
Sure.
hoping I could raise to you. One of them is just focused on, have you experienced challenges for kids staying longer than necessary because they can't return home or to the place where they're staying? And if so, what solutions did you find?
So we have not had anybody that has stayed longer than those 10 days. And thankfully, I have an amazing discharge planner that I've had since day one. So get good staff is my first step. But second of all, I can count on my hand how many people since 22 have stayed that full 10 days. And usually those are complex placement issues. It's basically what that question is alluding to. But usually we know within the first couple days or so if there's a disclosure or a family member that doesn't feel confident taking that child back into their home. We're working with our local Department of Children's Services or other treatment centers to make sure we have a plan. We have not exceeded that 10 days to date, but I think it's just rigid or lots of coordination, like every day, just making sure that we're pushing, to make sure that kid has a stable plan after that. And then we always have, wherever they land, the good thing about the continuum, they can go right back to those walk-in center services. So there's always an aftercare plan. I saw a question kind of about that. Where did they go? We looked for long-term options in their county of residence, but the good thing I think it has impacted them being able to leave within those 10 days is that there's always an aftercare option for them. We have those services already in the continuum.
That's fantastic, Lindsay. And there are a bunch of other questions in the chat. If you get a chance, to take a look. But also, I know some folks dropped your email in the chat, so I know you encourage people to reach out as well. Thank you so much for the presentation, but more importantly, thank you for the work that you're doing. And also thank you to Janice and Ron. All right. So next, we have up our crisis talk session with Stephanie Hepburn, a little bit of a slightly different structure since Stephanie, you were both the writer and the interviewer. So I'm stepping into your big shoes. I mean, I have no idea how big your shoes are, but your metaphorically big shoes as the interviewee. So Stephanie, please tell us about the work that you did and then wrote about under Childhood Interrupted, the pandemic toll on kids.
Thanks, Aisha. First, I think also just want to highlight how amazing this presentation was. I would love to do like a series with Lindsay and Janice and Ron, because I think what communities are really trying to dive into is some of these gaps are very clear, but how do these partnerships get built, and how do just the logistics, even hearing about how the hospital leases, I just think the nitty gritty is really important for communities to know about.
Yes, I have to, I mean, the amount I've done a lot of consulting for communities across the country, and I'm always surprised at how much just this very specifics of how do you build a partnership, how do you find it, all of that is so important, and people have figured it out in different places. Being able to share that information is crucial. So I just want to jump on that point and validate, but please.
Well, and I think sometimes there's a misunderstanding within communities that their community is so different. It's like we hear all the time, mental health, looks like this in this state. And those nuances are very true. But a lot of these lessons learned can be applied and replicated. So I love your point. So what I wrote, it was published in mid-July, and it's a paper for the Think Bigger, Do Good series, and it's called What About the Kids, Child and Adolescent Crises, the Pandemic in 988. And what I was struggling with is, we were hearing a lot, kids are having a tough time. I think it was the Academy, so the American Academy of Pediatrics and other child health focused organizations declared a national child and adolescent mental health emergency. But I wanted to know, what does that mean exactly? I was finding little pieces here and there. but I wanted to dive into data and try to create as much, it moves really quickly. So looking at what it is today will look different. Most of the research that I did went through 2020. Some of it went into 2023, but you're always a little bit behind the ball, which is frustrating. But as a parent and watching my 10-year-old and 15-year-old navigate the pandemic and have their childhoods interrupted, and seeing that, and knowing that it's not monolithic. I know that it's different in different communities. Even within New Orleans, some kids went back to school rather rapidly, other kids didn't. How did that create, what did that do? Some kids were hybrid for a long time. What did these challenges do? If you're already marginalized, how did that impact you? So, but I just wanted, instead of it to be my own, lens, I wanted to see, what does the data say? What happened? And so I went back to interviews that I'd done for Crisis Talk. It did more interviews to get some information and say, did going back to school, was it the fix that many of us hoped and thought it would be? And so that's what I did. I dove into that data.
So Stephanie, there's so much in this article, and people, please go read this. It's really amazing what Stephanie found. Stephanie, give me your 30 seconds though on the most surprising thing.
Yeah, so I had done an interview for Crisis Talk, interviewing folks from Youthline, which is a peer-to-peer hotline in Oregon. It's a Lines for Lifeline. And I wanted to see, after kids returned to school, what happened to loneliness. And what was fascinating and stark to me was that it increased. I had assumed that it would decrease, but it didn't. It increased slightly from 12% to around 14 to 15%. And what also surprised me is that youth contacting kids, children and adolescents contacting the line about mental health concerns, it doubled from 17 to 35. And so I started thinking, why is that? So I tried to dive into that as well and look into school data and some of the surveys, which indicated that, there wasn't a handbook in many communities to go back to school. What did that look like? It's like we turned the switch off and we turned it back on and we're like, yay, like it's all fixed now. And, there was a lot of chronic school student absenteeism, but also teacher absenteeism. And it wasn't always because of the virus. I mean, it was because life was interrupted economically. I found a report where kids did poorer on one of their, it wasn't LEAP, but it was another standardized test. Yeah. And it was correlated with parent unemployment in that area. It's just disruption. What does that do? When there's this kind of interruption, what are the echoing effects? And what are those effects going to continue to be? And how can we address them? But also schools reported that the pandemic harms students' socio-emotional and behavioral development. And
there's a lot of complexity into that. Yeah. So Stephanie, thank you. Thanks for the work. Everyone, please do read the article. I'd love to hear folks' thoughts in the chat too about what they just heard and what that surprising finding. All right, Stephanie.
Thank you.
Thank you so much. See you next week. Okay, so moving on, I think we have Richard McKeon to do the SAMHSA update.
Thank you so much. A pleasure once again to be with you. So I have several things I was going to touch on. One is that I'd mentioned a number of weeks ago that the National Emergency Number Association, which is the group that sets voluntary standards for the nation's 911 public safety answering lines, had out for public comment their proposed standards on 988 911 interaction and collaboration. That public comment period has now closed, and where that process is now is the is that the comments that were received will be reviewed in a series of meetings, actually starting later today. Both myself and Shai Lewis from the Lifeline are on that group that will be looking at the comments. After that, it will move toward finalization of these draft standards, finalization and release and publication. So I think I don't know exactly how long that process will take, but I think we are still several months away from the release of these. But I think it will be quite important for all of us when they are released, because this will be something that every 911 PSAP across the country will look to. And we actually had a conversation on the Run of Show earlier today about extending an invitation to the National Emergency Number Association to come to the Crisis Jam to speak about that at an appropriate time in their process. So we will be following up, on that. Secondly, I've reported a couple of times in the past on the efforts to revise the National Strategy for Suicide Prevention, and which is now the target for the release of the national strategy, the revised national strategy, and an accompanying action plan and action agenda is March of 2024. So we're about 5 months away, from that. Currently, our main focus has been to work with federal agencies to identify, because the action agenda is strictly a federal action agenda. There are, of course, many more actions that we would hope the private sector would be taking, and I think the Action Alliance for Suicide Prevention will be instrumental in that. Also, there is next week in Golden, Colorado, a Living Beyond Suicide Summit that will be really looking at 988 and its implications for people with lived experience, particularly suicide-related lived experience. This is being put on by United survivors, including Eduardo Vega, Sally Spencer Thomas, and others. Both myself and Michelle Cornett from SAMHSA will be there for that. And then finally, I just want to mention these excellent discussions regarding children's mental health and children's treatment services. One thing that I think is useful to note is that the preliminary 22 data that CDC released, somewhat surprisingly, considering there was an overall increase in suicide in the United States to the highest number, not the highest rate, but the highest number that we had. But the rates for youth age 10 to 24 actually went down. So it's worth trying to understand better what led to that, because that was certainly a positive sign. One possibility could be the increased access for 988. One thing that we know for sure is that compared to 2021, we know that every single day, hundreds of currently suicidal youth aged 10 to 24 were accessing the chat and text systems for 988, and that doesn't count any additional phone calls, but we do have the data on chat and text.
That's great.
Yeah, and also chat and text is becoming more localized. More centers are doing it locally, although we still have heavy reliance on a core group at Chat and Text Center. But the numbers where it's locally based chat and text has been increasing. I'll stop there.
All right. Well, thank you so much for the SAMHSA update, and good to see you. I'm next going to call up Deb Pinos for the NASHBID update.
Well, hello. It is a pleasure to be here, as always. Nice to see you, Aisha.
Yes, nice to see you.
Love the presentations that came before. So I'm going to talk about NASHBID, and I'm going to take the opportunity to highlight another one of our papers that are coming out. We really like to celebrate the work of our colleagues. As I've said in prior crisis jams, we put together a series called Connected and Strong Strategies for Accessible and Effective Crisis and Mental Health Services at the request of SAMHSA. A lot of great authors contributed to this. Recordings of the presentations are on the NASHBID website. Today, I'm going to highlight one that I think is really important. I picked paper number 9, Intersectionality, Faith, Mental Health, and Community Partnerships as the key, because I think we have so much going on. And we really do need to stay connected to each other in this era of social isolation and so many political issues and complex trauma that's going on in the world today. And we really want to have strong mental health services, which involves thinking about partnerships. So this paper was written by authors at NAMI. Dawn Brown took the lead, and you can see the other authors here. It was a great collaboration. And my colleague Jenna Schofield at NASHBID and I co-edited the series. And they really focused on how to bring faith-based partners into those partnerships that we really need. So I'm going to go to the next slide and give you just hit the highlights that you're going to see in the paper. First of all, they spoke about spirituality and religion, and really thinking about spirituality as the part of the human experience related to the transcendent, the sacred, or ultimate reality, and is related to values, meaning, and purpose in life. And then religion, which is a system of beliefs and practices related to the sacred or divine, followed by a community or social group. And the paper focuses on both aspects of faith in this way. Next slide. And we got a great quote from Pastor Veron Blue from the Family Life International Ministries. Many people reach out to faith leaders when struggling with mental health issues for themselves or their loved ones. This is particularly true of African-American community due to distrust in the medical profession, and because there are few African-American mental health practitioners or resources that represent the African-American experience. The long history of African-American churches in the US makes them a logical resource for their communities. Just highlighting the importance of a faith-based community as part of our partnership in crisis prevention and intervention. Next slide. So highlights from the paper, and I'm not going to read all of these are available to you, but I'm just going to hit some strong points. Religion is either very important or somewhat important in the lives of 66% of US adults. So we can't forget that. And it offers, both religion and spirituality offer protective factors against mental health conditions and suicidality. I know in my own lived experience, leaning on my faith has been incredibly important, and we want to remember that. And so faith leaders hold positions of power and influence in their communities and are well positioned to engage in stigma-free initiatives and mental health advocacy. Yet they may need some additional training. So we want to reach out, incorporate faith-based partnerships as part of our community partnerships as we build out the crisis continuum. Next slide. The paper goes on to recommend policy impacts and recommendations for policymakers and leaders. Many of you are on this call to think about how do we educate our faith partners and culture partners into what we're doing, and how do we incorporate faith and seek funding for initiatives and highlight faith-based partnerships in the funding that we have to help bridge faith-based partners into our mental health and substance use intervention, suicide prevention, and then thinking about their role in supporting communities. Really engaging faith communities to identify gaps that might exist, incorporating them into the design, implementation, and promotion of our 988 efforts, and then considering the value of qualitative metrics as we look at these interventions and these other partnerships, and what can we learn from those partnerships, and working with faith communities to incorporate and expand the availability of peer-to-peer support. Again, peer support being such a critical part of the infrastructure of our crisis continuum. because they offer such a resource for compassion and hope from those with similar beliefs or backgrounds. So those are some of the things you're going to see highlighted in the papers. And I think it's a fantastic opportunity to think about faith-based partnerships and really expand upon them in the work that we're all doing. And I just want to wish you all well for the rest of your day, and keep going, and we'll get these papers out for everyone, and there's more to learn from them. And you can get the information on the NASHBID website. So thanks, Aisha.
Thank you so much, Deb. All right, let's get into the last bit and the wire. So Tom Betlach, Medicaid front and center. You're up.
Thanks, Aisha. Great to be with everybody today. And the theme I've heard over and over is partnerships. So I'm going to partner with Stephanie, and we're going to tag team to shine a spotlight on mobile response teams. I'm putting some resources into the chat and just highlighting a few things. The first is, it's been almost 2 years now since CMS issued guidance to states on mobile response in terms of being able to leverage additional resources that are available to states for mobile response. And so it's a 17-page letter. It's pretty dense, but it highlights some important themes for states to be thinking about. And again, under the premise of partnerships, it's really an opportunity for behavioral health organizations to partner with Medicaid and partner with the Bank of Medicaid to look at financing opportunities. Because one of the first main themes is, for 3 years, states can receive enhanced funding for mobile response teams for Medicaid members. So in essence, states can put up 15 cents for every dollar, and 85 cents will be covered by the federal government. So those additional resources can be really key to growing and sustaining mobile response services as part of the overall continuum. There's a lot in that guidance. I also provided a link to the State Health Value Strategies summary of that guidance. So they took those 17 pages, condensed them into just a couple of pages that really highlight some of the important themes associated with the mobile response guidance that was issued by CMS. I also provided a link to Oregon Health Authority that has an entire web page of resources on mobile response. So a shout out to them. Also highlighted within that are several episodes of the Crisis Jam that have talked about mobile response. So it's just a very comprehensive resource that's available out there on mobile response teams. And then finally, I actually included one of the state's approved state plans. So there's this bureaucratic process that Medicaid programs have to go through in order to get this increased funding. And I provided an example of what Arizona did in terms of being able to get that authority. So with that, Aisha, I'm going to turn it over to Stephanie, and she can go over the map and talk about sort of what states have been able to move forward on mobile response.
Yeah, thanks so much, Tom. Yeah, I think it was up earlier, but we showed a map so far at NAMI. There it is. We have tracked 11 states that have taken up that enhanced Medicaid mobile crisis match that Tom was talking about, that was afforded to states through the American Rescue Plan Act. And really, the underlying point to take away from this map is sort of what Tom was saying, that most states have not tapped into this option yet. And we certainly don't want to see states, leave money on the table. So if you are involved in 988 advocacy financing in your state and you have not heard any discussion about the state taking up that enhanced 85% FMAP, it's definitely worth exploring with your state Medicaid department. And also, I'll just say, take this map with a grain of salt for now. I realized after I sent this in that we are missing a couple of states. California and Washington should also be lit up. So I'll add my email in the chat if folks have any other additions or corrections that we should be making to the map. And we'll follow up on a future call with an updated map.
That's great, Stephanie. There's a quick question. Is the map on the Reimagine Crisis webpage?
Not yet. We are looking to do so, but it is not live online just yet.
Okay, and just one last one. You can't escape me just yet. But you made a great point about folks looking into what their state's doing and investigating that. If people want to have get some advice or we'll think about like resources for how to do that advocacy around the match. Any thoughts about that, where they can look?
I think the National Association of Medicaid Directors has an issue brief on this opportunity, as well as I think Kaiser Family Foundation has some good plain language resources. I will try to dig those up and throw those in the chat.
Great. Thank you so much. Thank you, Stephanie. Thank you also, Tom. And so next slide. We are coming to the end of the Crisis Jam. I want to thank all of you for being here. It was a really fantastic presentation, and thank you to all of our speakers who were here with us today. Definitely make sure to tune in next week for the 150th episode. And following week, 151st episode on crisis services in rural communities, which of course has its own, rural communities have their own specific needs and challenges for standing up strong crisis services. And I know that that is a perennial question throughout the career I have had about how to make sure that rural communities are covered sufficiently with crisis services. And so with that, I just want to say a big thank you. Make sure to go to the Crisis Jam website and get all of the resources that we talked about today. Make sure to remind people, final thought, remind people to register ahead of time so that they can make sure to join the Zoom the week they want to. I didn't register ahead of time and it caused me a bit of panic, but we're all here. We made it through. Everyone have a great rest of your Wednesday. Have a really, really wonderful week. And I will see you here next week. I won't be hosting, but I will be here. And I realized at the top I didn't introduce myself. So I used to be Delaney Brumsey. I'm the Chief Strategic Growth Officer at Fountain House in New York City. All right. With that, have a very good week.